Well, it's nice to make that connection with you. I'm sure there's lots of interesting projects going on in different places that we can
Oh,
kind of
yes,
learn
for
from each
sure.
other.
Yes, for sure, for sure.
Hmm.
That'd be really good.
Good evening, everybody.
Hi there.
Hi, nice to meet you, Dolores. Thank you for joining us.
No problem. Thanks for having me.
We're just sorting out a few last-minute logistics because we streamed this on our YouTube channel. So we were just putting in the YouTube parameters. There was an error in the link, so we're just fixing that now.
Okay.
We've actually had a lot of interest in today's event. I think over 60 people have registered to attend.
Awesome.
Yeah, so it's prayer time now, so they will be joining in the next 3 to 4 minutes. So most people are probably just finishing off their prayers.
Okay. No rush.
Yeah, and thank you as well to Monica for joining us.
No
So
problem.
I work alongside Monica in the College of Pharmacy.
Very good.
Have you been out here to Delphi? Because I know some of your colleagues have.
No, I haven't. I don't work directly for RCSI. I work in a psychiatric hospital, but we have I suppose a close relationship with RCSI for teaching, and I suppose we've gotten involved in looking at the curriculum and aspects like that, maybe a little bit more than a normal kind of clinical relationship between the university and the teaching site, I suppose. So yeah, so I don't work directly with RCSI, so I don't get the perks of going off to interesting places.
Well, Ireland is pretty interesting.
I'm not sure. Yeah, it's nice. It's a lovely day here today, so everyone's in good form when the sun is shining.
Okay, great. How's the restrictions now? Have they taken after England and eased all travel restrictions now?
Yes, everything has been taken away, apart from wearing masks in healthcare settings. I think that's the only restriction that's left. But our cases have exponentially grown in the last couple of weeks since those restrictions were eased. So, how about you? Where have your restrictions been eased?
Uh, so over the past probably 6, 7 weeks, they have been easing, not to the extent that you've just described. So we don't have to wear masks in when we're outside, but in all indoor areas we are still required to wear masks. In terms of travel, um, I know there was some updates actually a couple of days ago, but I think we still have to do a pre-travel PCR test, and then once we arrive back, we need to do another PCR test within 24 hours. Um,
It's not PCR though, it's only
oh
rapid
yes, the rapid
antigen.
antigen. Yeah. Excuse me. Yes, the
Yeah.
rapid antigen. That's right. And we have an app here called Ihtiraz, and that displays our vaccination status. So unless you're fully vaccinated, I don't think that you can enter into malls. Is that right, Monica? I'm not sure. I'm vaccinated, so I don't really follow it too much.
Yeah.
Well, I don't know. I don't know if you can do that, but
Yeah. We used to have that. So we have an app as well with our vaccination status, but they've taken it away. You used to need it for, going to a restaurant or a cinema, anything like that, but that's been eased as well. Um, I don't know. It's kind of gone out of the news a bit at the moment, so people have forgotten a little. Um, Unfortunately, there's other things that have made the headlines.
Yeah.
But
yeah.
yeah, so we just have to wait and see. I'm sure we'll need another booster at some stage shortly.
Sahar, can you make me the host, please? Or if you could make me the presenter. Thank you. Okay. So I think our attendees are slowly trickling in now. So I think we'll make a start. So good evening, everybody, and welcome to this evening's CPD event. Today we're going to be focusing our session on understanding mental health first aid. And before we introduce our speakers and moderator today, I would like to just to welcome them on behalf of the CPD unit here at Kotte University. So we have Dr. Dolores Keating and Dr. Monica Zaletsy, and we'll do a more formal introduction in a few moments. Just to bring you up to date with our current schedule. So this event has been rescheduled from last week, and then next week we actually have another event coming up. So next week we'll be having an event at the same time, so on Monday from 6 p.m. and we'll be talking about the social determinants of health and clinical outcomes with a focus on diabetes. So we look forward to welcome you to that event. Registration is now open, so please submit your registration forms. As always, we look forward to your participation in today's event, so please use the chat function. We're also streaming live on our YouTube channel as well, which we'll be monitoring throughout. So I look forward to you sharing your experiences and your questions. Okay. So I think what we're going to do now, we're going to hand over to Dr. Monica Zaletsy, who will be introducing today's event and today's speaker. Thank you very much.
Thank you, Dr. Sack, and welcome everyone to today's CPD event. It is a pleasure to introduce you to Professor Dolores Keating. She's a pharmacist with almost 20 years experience in psychiatry. Dr. Dolores qualified in 2000, having completed her undergraduate qualification at Trinity College in Dublin. Following her initial experience working at a large acute teaching hospital, Dolores began her career at St. John of God Hospital in Dublin as a senior pharmacist in 2003 and was subsequently appointed head of pharmacy in 2005. St. John of God Hospital is an independent provider of mental health services with 183 inpatient beds. Care is provided for people in the local catchment area in addition to a national, secondary, and tertiary referral center. Dr. Dolores completed a postgraduate diploma in psychiatric pharmacy with Aston University, followed by a master's in clinical pharmacy with Queen's University in Belfast. In 2012, Dr. Dolores became a credentialed member of the College of Mental Health Pharmacy in the UK. Dr. Dolores is passionate about the contribution of pharmacists to the care of people experiencing mental illness. She has worked extensively with the profession in Ireland through the development and delivery of continuing professional development programs. She is a member of the Mental Health Working Group of the Irish Institute of Pharmacy and as National Liaison Pharmacist to the Mental Health Division of the Health Service. Between 2015 and 2018, Dr. Dolores Project managed the introduction of the Mental Health First Aid Training and Research Program in Ireland. As Dr. Dolores will be presenting to you today, Mental Health First Aid is an internationally recognized skills-based training program supporting members of the public to communicate confidently with people experiencing mental health problems and encourage them to access appropriate help. Mental Health First Aid Ireland has now trained over 10,000 people and has been integrated into the undergraduate program. We welcome Dr. Dolores in today's CPD event. Thank you.
Thank you very much. Will I share my slides now? Yeah. Now, you okay there? So thank you for that introduction. I feel terribly old after listening to that big long paragraph. And I'm delighted to be here today. Thank you for having me. And I'm coming to you from actually quite a nice sunny Dublin this afternoon. So as I said earlier, you know, we're always in good form in Ireland when the sun is shining, because we don't get that much sunshine, unfortunately. So I've been asked today to come and talk to you about understanding mental health first aid as a training program. So I thought what we would talk about would be to talk about the scale of the opportunity, and that's what it is. It's an opportunity to improve the care of those experiencing mental health difficulties. That we would learn a bit about the mental health first aid approach. So what it is as an educational intervention, how it was developed, and the research and outcomes that have been, I suppose, evaluated over the last 25 years on this program. And then we can think about how mental health first aid could support public mental health policy. And that includes areas such as earlier intervention, gatekeeper training, scaling a program. So a program with the potential, I suppose, to make a significant impact from a public mental health perspective, and how it might be used in the occupational health setting. And then reflect on how mental health first aid has been incorporated into education and training programs for healthcare professionals. So to start, I suppose, and to contextualize, we'll have to think a little bit about the scale of the issue. And I know a lot of people are very familiar with a lot of these statistics, but it is important, I think, to reflect on them again, and to really think about how frequent it is and how often we will, as citizens, as family members, as communities, as well as professionals, how often we will come in contact with people who are experiencing mental health difficulties. So we know that 1 in 5 people will have a diagnosable mental health condition each year, and that 1 in 2 people will experience a diagnosable mental illness in their lifetime. And 1 in every 3, and this is maybe an Irish statistic, but 1 in every 3 attending their family doctor has a mental health aspect to their medical problem. Now, the cost is significant. Total cost estimated at 3.5% of GDP. Now, I personally find that quite difficult to conceptualize what that means. But when you think about it, there's the cost not only of treating the illness itself, but the loss of productivity that's associated with it, the poverty and marginalization that a lot of people who are experiencing severe mental or serious mental health difficulties will experience. And we know that many people who experience mental health problems do not seek help. There's lots of reasons why that might be the case. Maybe there's the stigma associated with experiencing mental health difficulties. It could be because they think that there isn't any help available, or the help won't be good enough for them, or won't be helpful for them personally. So there's lots of reasons people don't seek help, and maybe they don't have the hope that they need, that treatments will help them to recover. And we need to always remember that people can and do recover from mental health problems. People with serious mental illnesses experience huge amounts of disparities in terms of their treatment for their physical health problems. So the life expectancy for people with a serious mental health problem is 15 to 20 years less than people who don't have that difficulty. And we see it in lots of different areas of physical health care, such as in that infographic there, which came from the UK, but, you know, cardiovascular health, people have poorer outcomes from treatment from cancer, for example. And recently, I think over the last week, there's a campaign being launched, which is called The Right to Smile, highlighting the impact of mental health problems on oral care and highlighting that people are more likely, for example, to lose all their teeth or get oral cancers if they also experience mental health problems. So there's this huge disparity in the physical health care and the life expectancy between people who are experiencing serious mental illness and those who don't. And it's some of it may be attributable to suicide, for example, but most of it is attributable to physical health conditions. So as far back as 2003, the WHO said that mental health was the most important public health issue, which even the poorest society must afford to promote and to protect and to invest in. But we know it's actually not prioritized in the way that the WHO envisaged. And for example, the WHO would say that about 12% of a total health budget should be spent on mental health, whereas in Ireland, as of last year anyway, we were only spending 6% of our total health budget on mental health. So there's a large gap there, isn't there? And then we also have the potential impact of COVID-19 and the pandemic on the mental health of our citizens. So it's difficult to know the full impact of this just yet. But a large study in The Lancet recently, which looked at 204 countries or territories, found that the prevalence of mental health problems was increased, and particularly major depressive disorders and anxiety disorders. And that was in the first few months of the COVID-19 pandemic. Then we still have to find out, I suppose, what the the impact of long COVID, as well as it's known in Ireland anyway, or the post-viral syndrome that seems to be associated for many people who have a COVID infection, and what impact that will have on the mental health of those who experience it. But we do know that people with chronic health conditions of all kinds are more prone to experiencing mental health problems along with that. We know that there's been a disruption to health services. So people have perhaps delayed presentation for physical health problems or issues such as cancer treatment, and that will also have an impact on their mental health. In Ireland, we're certainly seeing this in the area of youth mental health for young people, and also we're seeing large impact for the treatment of eating disorders has been a particular pattern, I suppose, in the Irish healthcare setting. And we really need to think about what the impact of the pandemic has been on our healthcare professionals. I saw a survey from an American group recently, which said that 75% of the people that they surveyed anyway were thinking of leaving healthcare as a profession. And I do know that a lot of people are thinking and reevaluating their jobs and their ability to continue in very pressurized environments. So certainly in Ireland, we've had to think about how we can actively assist our healthcare professionals to recover from the impact of the pandemic. So overall, what I would say is that no matter what your profession, as a member of a community, mental health is an important topic, and we will all be in a position to help someone who's experiencing a mental health problem. So today, we're talking about mental health first aid and how this training program, or this concept even, could fit into a population health approach. How might it help professionals or healthcare professionals help our patients and also to help each other? And we know that there are huge efforts all around the world to improve awareness and understanding of mental health problems. But for me, the mental health first aid approach and why I was really attracted to it or taken by it was this was really about the next step. It was moving from having that awareness to taking action. So what could I do to help someone, or what could we do as a community to help someone experiencing a mental health difficulty? So mental health first aid, it's a skills-based training program, and it aims to equip members of the public with the knowledge, skills, and the confidence to provide support to those experiencing mental health problems. And I've highlighted the word confidence there because I think that's always, that seems to have been difficulty, I suppose. We can learn a lot. We can, we've all got access to quite a lot of information, but have we got the confidence to have that conversation? And that's what I really liked about mental health first aid. So it's defined as the help offered to a person who is developing a mental health problem or experiencing a worsening of an existing mental health difficulty or in a mental health crisis. And this help is provided until appropriate professional help is received or the crisis resolves. So it's important to say that this isn't a program that teaches anyone how to be a psychiatrist or a psychologist or a counselor. It's really around how can you support someone on a first aid basis until they receive the appropriate help or the professional help, perhaps, that they might need. And perhaps the first aid is all they need. Maybe that's the intervention that's enough in that moment. However, it is about first aid, and I suppose an important message is that it's not about, a first aider's responsibility to shoulder the burden of that difficulty for another person. It's in a similar way to physical health first aid. We're, helping them to access the appropriate care and to access the professionals who are trained to provide professional help. So if we think about physical health first aid, what are we trying to do? Well, in physical health first aid, we're trying to preserve life. We're trying to stabilize the situation and prevent further harm. We want to do something that will promote recovery. And we want to provide comfort to a person who might be ill or who might be injured. And they are similar to the aims of mental health first aid. So what we want to do as mental health first aiders is to preserve life where a person might be at risk of harm. You want to provide help to prevent the mental health problem from becoming more serious. You want to promote recovery of good mental health and provide comfort to a person experiencing a mental health problem. So, as I said, it's typically offered by someone who's not a mental health professional, but it might be someone in a person's social network or maybe in a human services occupation. So, just to say, what is the course then, or what is this educational intervention? So it's a 12-hour course. It has 4 modules and each with 3 hours. So you can deliver it, when we deliver it, we can deliver it over 2 days, and usually we do deliver it 2 days together. And that's for reasons, related to developing a nice group dynamic and people getting to know each other and being comfortable with each other in a particular training course. But there are 4 modules, and sometimes it's delivered separately over those maybe 4 weeks, for example. When I say it's skills-based, what I mean is that we're really trying to practice our communication skills within the course, and that there are discussions, scenarios, role plays, video content, all different ways of engaging people with different preferences, I suppose, in how they learn, and how, so that everyone can get the most from the program. And I suppose one of the things I've actually participated in mental health first aid on numerous occasions as a participant. I've done it several times, and one of the things I always learn from the people who are with me on the course. I learn from their stories, and I learn from their experiences. So it's a positive learning environment that we try to create, and that everyone's experience is valid and of interest to us. What we learn, there's a knowledge aspect to it. So we do talk about the signs and symptoms of mental health problems. And I suppose it's different to the way we might learn it as, say, professionals. You know, it's not a list of symptoms, for example, with technical terms attached, but it might be, well, what would I notice if my friend wasn't feeling well? What might it look like to me if my colleague was experiencing some mental health problems? We learn about what sort of help has been shown to be effective. And again, that's evidence informed. And also, we don't all have the same understanding of, for example, the role of medication in treating or supporting people with mental health problems. We may not all know exactly what is meant by the different types of psychological interventions, different types of occupational therapies, for example. So what we learn in this is factually, well, what do all of the professions provide? And what kind of help is being shown to be effective? And it's not all professional help. There are other supports that for people as well. And we do this through we learn the communication skills through a framework for communication, which I'll show you in a moment. And that gives us something there in the back of our minds that we can have as a support structure within our conversations with people who are experiencing difficulties. So what we're learning with this framework is how to offer and provide that initial help, and how to guide the person and support them to access appropriate professional help. So the standard course would include the most common mental health problems of depression, anxiety, and substance misuse, and also psychosis. So psychosis, as we know, it's not perhaps quite as commonly experienced as depression or anxiety, but it is a topic that people have. There are a lot of misunderstandings about, so it's always a really important piece to include within the mental health first aid course. So the crisis situations and scenarios covered would be suicidal thoughts and behaviours, self-harm, which can also be referred to as non-suicidal self-injury, panic attacks, traumatic events, severe psychotic states, or the effects of alcohol or drug use, and aggressive behaviours that may occur in the context usually of substance misuse is where we would most frequently see that. So this is the content of the program and how we try to deliver it. And that's the action plan for mental health first aid, ALGE. So as I said, this is a framework for communication. So when I talked about physical health first aid, I suppose we tend to approach that in a stepwise approach. You know, maybe, I'm not sure if it's still this way, but ABC, you know, airways, breathing, circulation, you know, you're checking things in a particular order. With the mental health first aid action plan, you're using your judgment about the order and relevance of these actions in a particular scenario, and you need to be flexible in your approach and responsive to the person that you are talking to. So within the program, what we would do is have lots of different scenarios and group discussions around how you might use the action plan to help someone in that particular situation. So for example, you've noticed someone who may be, you think, experiencing a low mood, for example. Now, again, we're not teaching people to diagnose anyone. That's not our role as mental health first aiders. Really what we're doing is noticing if someone isn't quite themselves or something has changed for them. And there are some things that we might notice that could perhaps point to or signal that they are, for example, experiencing depression or anxiety. But really what we're doing is noticing that something isn't quite right, and how will we approach that person and assess and assist for the potential for any crisis. So in the original, the very first iteration of mental health first aid, it actually just said assess and assist in any crisis. But through their research and through the development of the guidelines, they understood what, how important that approach is, and how you approach someone if you're worried about them or concerned about them. Listening and communicating non-judgmentally is something that we will do throughout this conversation. And then we can have the knowledge to give support and information, and encourage the person to get appropriate professional help. So we might be the ones who are able to tell them, well, what is the difference between the psychologist and the psychiatrist? Or where might you look in terms of good and real information sources on the internet, for example? Or what can your general practitioner do for you? So we have that factual knowledge there to help them, and to help them make their own decision about what they want to do or the next steps that they might want to take. And then there are other supports. So this isn't necessarily a medical model. It's what we would call, or we think of as, a recovery model. So, there are lots of other things that people can do to support their health and well-being, or to gain support. And it depends on the difficulty they're experiencing. It might be financial help, for example. It might be, talking to a close friend, or perhaps engaging in a peer support network where other people have experienced similar problems. Or it could be a self-help strategy, for example, or a self-help strategy that's also supported by a mental health professional. So that's ALGE. It's the action plan that we use. And I've personally experienced how you use this in my own life. And what happens is, I suppose, that it's there in the back of your mind as a framework. And when you come across that situation, you have that there as a support structure for you to help you to help that person. And it is actually practically useful in my own experience. So the course was developed by an Australian couple, and there they are at the launch of the international, that was the first international conference on mental health first aid. And there we have Betty Kitchener and Professor Anthony Jorm. Now, Professor Anthony Jorm is a Professor Emeritus at the School of Population and Global Health at the University of Melbourne. And I think you'll see his influence throughout this program in terms of how he has supported the research, and how it's a research-informed program, and also in how it's been evaluated. So he is a highly successful researcher in the area of public mental health. And that's his wife, Betty Kitchener. Betty Kitchener is a nurse by profession, and she was a certified teacher in physical health first aid, and taught her colleagues about physical health first aid in Australia. And she herself has experienced mental health problems. And so I suppose herself and Professor Jorm there thought, well, if you can have first aid for physical health, why can't you have it for mental health? And I do really like this quote from Betty. She said that she often wondered what life might have been like if there had been mental health first aid when she was young, and that people could have understood what she was going through. But then if she hadn't gone on to have repeated episodes of severe depression, then she might not have developed mental health first aid. So I think it's interesting sometimes, you know, to think about what might have been. But for Betty, she considered the universe to have had a plan for her after all. So in terms of the course content, it's based on guidelines which were developed by researchers using the Delphi expert consensus approach. So the Delphi method, it's something that can be used when you're answering questions that are not amenable to maybe experimental or epidemiological methods. So in practice, what they did was the lead researcher looked at all, did a large literature search, including the grey literature, to come up with a list of actions that might be helpful or might be unhelpful when having a conversation about particular mental health conditions. So that formed the basis for an expert panel of patients, caregivers, mental health professionals, and academics to work in panels and think about whether they agreed or disagreed with these statements. And if there is a consensus, then the statements are kept and they are used to inform the guidelines on what could be helpful. So what might be a helpful action for someone experiencing various mental health difficulties. So they've done that for lots of different issues, including depression, psychosis, panic attacks, for example, eating disorders, gambling problems. And they have adapted or thought about how you can adapt this in different cultural contexts. So all of that information has been published, and the guidelines are all available on the Mental Health First Aid Australia website for people to review, and they're regularly updated. So that they maintain their relevance, and that we can maintain the relevance of the course and when we're reviewing those. Okay, so in terms of course evaluation, there's been several ways of doing this, and you can see there all the different, I suppose, levels, or traditionally what we think about as different levels of evidence have been used. It's an extremely well-studied concept and program. It's actually better studied than physical health first aid as an educational program. We've had systematic reviews, RCTs, controlled trials, so they wouldn't have random allocation, but they might be waitlist controlled, so everyone does receive the intervention. Uncontrolled studies, qualitative aspects of the program have been studied, and we've looked at longitudinal studies as well. So I thought we might have a look at how you evaluate something like this, because, well, I find it very interesting anyway to think about the methodology and how would you know if what you're trying to achieve is being achieved through your course. So mental health literacy is one way that you can maybe decide, I suppose, whether the knowledge has been gained or what you're looking to impart has been achieved. So we know that, say, health literacy, it's an accepted thing that anyone, if you increase health literacy, that people will take more control of their own health and well-being, and that they will be able to have better outcomes because of that. So health literacy is the ability to gain access to, understand, and use information in a way that promotes positive health and maintains good health. So, for example, being literate about what a healthy diet is, you know, knowing maybe what the signs of a stroke might be, how to check for perhaps a cancer. These are all health literacy concepts. With mental health literacy, then, in a similar way, it consists of several components. So the ability to recognize specific disorders or different types of psychological distress, knowledge about risk factors and causes, beliefs and self-help interventions. What are your beliefs about professional help available? Attitudes which facilitate recognition and help seeking, and knowledge of how to seek mental health information. So these are all aspects of mental health literacy, which has been studied in detail, and particularly by Professor Anthony Jorm himself. So the way you do that is that you would provide a scenario, for example, and then you say, what, maybe we'll call the person John, and you describe something that's happening for John, a little story, and ask someone, well, what do you think is going on? What do you think is happening for John? And then subsequent questions might be about, well, what do you think might help? And what interventions do you think are available that will support John to feel better? So that's how mental health literacy has been evaluated. And they've used this to see if mental health first aid has been effective. We also use stigma questionnaires. So even though mental health first aid wasn't really developed as an anti-stigma intervention, it has been evaluated in that way. So they would use a social distance scale, for example. And these are used in sociology and psychology to see how people are willing to participate in social contexts of various degrees with people from a particular social group. So it's not just for mental health, but for other social groups as well. So it would ask you questions like, for example, would you accept someone with severe depression as a close relative or as a close friend or as a co-worker? So these are standardized, validated scales for assessing social distance, which is one aspect or one way of evaluating stigma. And then a personal and perceived stigma scale. I suppose that's asking what I feel might be the overall view external to me and what I perceive might happen to me if I, for example, seek help for my own mental health problems. So what I perceive the stigma to be in that outside world, and perceived stigma will have an impact on how I access treatment, for example. As part of the mental health literacy, they've examined beliefs about treatments, self-reported confidence. So on a scale of 1 to 10, how confident do you feel to provide help for someone experiencing a mental health problem? They've also looked at whether participating in a program like this helps your own psychological health, the psychological health of the participants themselves. And they've used scales like the K6 or K10, that's the Kessler Psychological Distress Scale. So there's one that's 6-item and one that's 10-item, both of which have been validated. And really these are quick tools to assess for the risk of serious mental health issues in the general population. There's screening tools for that. And the short for the SF-12 is a similar questionnaire which looks more broadly at physical and mental health. So how do I feel, and what I suppose or has mental health first aid had any impact on how I feel as a participant? In educational settings, they've used OSCE exams to see if, I suppose, people are able to put their learning into practice. So an OSCE is an observed structural clinical examination. So what you might have is an actor or a simulated patient coming, for example, in my profession, to the pharmacy, experiencing symptoms or issues with their mental or emotional health, and in that examination setting, am I able to apply the learning that I had in the mental health first aid course? I suppose one area where there may be a gap in the evidence for mental health first aid is around outcomes and the impact on those who have actually received mental health first aid. And you can imagine that's quite a difficult thing to actually do and to evaluate. And maybe if anyone can think of a good way of doing that, we certainly would be open to suggestions and thinking about how we can evaluate our programs more effectively.
Dr. Dolores, if you
Yes.
allow me to just interrupt here so that I can read to you some of the questions that we have had prior to the methodology section.
Okay.
So we have a question about, just to be clear, they want to know if this course is designed to be delivered to members of the public. And if so, how do you identify suitable persons to undertake this training?
Okay, so yes, it was designed for members of the public. And I'll show you later how it's been used for people in many different professions, because we're all members of the public. There isn't any criteria for deciding if someone can be a participant or not. Anyone can be a mental health first aider in the same way as anyone can be a physical health first aider. And I suppose one of the concerns, perhaps, that some people had around mental health first aid was that people who had done the training might overreach or work outside of their capacity, I suppose, to provide care and intervention. But it's very clear in the course what your boundaries are and what you're trying to do as a mental health first aider. So I think it actually prevents that issue in terms of, people overreaching, as an example. So anyone can do it. And there are some different courses available. For example, there's a youth program which is specifically for adults who support young people. And there's a teen program for young people who help each other. So, yeah.
Okay, thank you very much for that nice answer to this question. Also, another question was about with the establishment of this initiative, was there a referral service or specific resources that have been developed? And I guess that brings me to the next question, which is how sustainable is it, this training? Like, do people have to continue receiving training, or is this like one-time training, and then how do you refresh yourself, those that have already been trained?
Okay, so first, in terms of the resources, you have to partner, first of all, with Mental Health First Aid Australia and show them that you do have the resources in your organisation to develop the programme. So St John of God Hospital is the partner in Ireland. However, we receive funding from the government to provide this training to members of the public. So they're very careful, first of all, that you can develop a sustainable and scalable programme for this. In terms of sustainability of the actual training, so the longitudinal study, I think I might have it later, but it showed that up to 2 years after, people did remember all of the, the key items from the training. So what we do in Ireland, and this is what's done, I think, in several other areas as well, is provide a brief update after 3 years. So it's not the full course again. It's 3 hours, just a refresher to remember, I suppose, scenarios particularly, and to update participants on maybe new interventions or new resources that are available. So that's the model that we have at the moment.
Okay, and would you have to, do the whole series, or would you just need to do a particular course, let's say an update on depression or on crisis intervention, or do you actually need to do the updates for everything?
So for mental health first aid, the update covers everything. That 3 hours is for the whole program as an update. So it's not, it should, I suppose, refresh you for all of the aspects of the course that you did originally.
Okay, thank you very much.
No
We
problem.
don't have any other questions about the previous material, so
Thank
happy
you.
to continue with the lecture.
So the systematic review, so how effective is it? So what are we looking at? And I think I've put up some studies here, and I don't mean to be so detailed about it, but I think what we're trying to get across here is that it has been quite extensively evaluated, and I suppose it helps us when we're delivering the program to understand, what are our targets, what are we trying to do, and what are our benchmarks, and what are we expecting from our program in comparison, and making sure that there's that consistency, and that being faithful to the mental health first aid program itself. So the systematic review was done by a group of Swedish researchers, so it's nice to see that it's independent of the Australian group in terms of the people who have looked at it. So there's almost 6,000 participants met the criteria for inclusion, so that's a decent number for this systematic review. And they found strong evidence of improved knowledge, recognition of mental health problems, and beliefs around effective treatments. So effect sizes, I suppose, they varied in this, or they were found to be at least of a small effect size up to sometimes almost a high effect size. So a high effect size might be 0.8, and the small effect size is around the 0.2. So in terms of stigma reduction, there wasn't a very large effect size, but most people opt to go to this course. They've decided, they have an interest, they want to learn a little bit more about it. So most people would probably have good attitudes towards mental illness or mental health at baseline. And then confidence in helping people with a mental health problem improved as well. So overall, in the systematic review, the authors concluded that it makes a noteworthy contribution to improving the lives of people with mental health problems. And I suppose that's the purpose, isn't it? That's the overall aim and what we're trying to do. I love qualitative studies. I love the stories. I think they're really impactful. I think, it's one of the best ways of changing attitudes or approaches is to listen to the stories that we hear from people who've experienced mental health problems, and also from the experiences of those who've tried to help them. So the qualitative studies, they might have done mainly for focus group participants or interviews. And they described gaining knowledge, skills, and confidence, and empathy. And that's key, isn't it, to helping someone, that we can show that we are empathetic, that we can be there with them at that moment. So you can see examples of when the skills were used, and it's not always someone you know. It might be a stranger. It might be that person sitting on the park bench on their own, or it could be a friend or a co-worker. Increased knowledge was reported, even though many people, as I said, have high levels of knowledge at baseline. So again, when there's self-selected samples, when people are coming because they're interested, they may have a good knowledge base already. Excuse me, I'm going to just take a drink. However, even though people had a lot of knowledge, the course offered new insights. And I think that's important, and I'll talk about it a bit later in terms of how you might use this for healthcare professionals and people you would expect to have a lot of knowledge in this area. And those who participated for their knowledge were likely to report a change in how they behave. And that's the real test of any educational intervention. Is it going to change how I practice, what I'm going to do once I've finished this course? And is that going to have a positive effect? And as I said, there's 2-year follow-up training, and it shows that the majority of participants actually used their training, that there were 88% in this particular study had encountered someone with a mental health problem at follow-up. And given the prevalence that we talked about earlier, we'd expect that, wouldn't we? We'd expect a lot of people to have encountered someone experiencing a mental health problem after 2 years, 2 years after their training, and particularly in this cohort who were public service employees. So for me, in terms of, investing in something like this and training, what that means is that it's actually useful. And I do an awful lot of training for my job. There's huge levels of mandatory training that I have to show that I've done and that I have to have certificates for. But very little of it is as useful on a day-to-day basis as mental health first aid, in my opinion. So the benefits appeared to be maintained. And then they asked about, well, what aspects of the action plan did you use? So people were listening non-judgmentally, or they may have provided an individual with information, for example, on how to access supportive help.
Dr. Dolores, can
Yes.
I interrupt you again? I have also a couple of questions regarding the methodology that has been used to evaluate the first aid, mental health first aid. So one of the questions is about the cultural sensitivity of this course. For example, in Qatar, as you may be aware, we have a very diverse population. Composed of many cultures.
Mm-hmm.
So another thing too here is that there appears to be a significant stigma around mental health. In your experience, using this intervention, is it relevant to multicultural populations? And if not, what adaptations do you see would be necessary?
Okay, so the original program was developed for English-speaking Western culture. It started in Australia, but they did include panels of experts from Ireland, for example, the UK, America. So the original program is designed for that cultural environment. However, it is absolutely recognized that it needs adaptation for different cultures. So, for example, in Australia, they would have adapted it for their Indigenous communities. As an example, I recently reviewed the article where it's been adapted for the Chinese population. And it's been adapted, for example, for immigrant populations in different countries. So what we do in Ireland is that we talk about cultural sensitivity as part of the programme. Ireland is becoming more diverse, but probably, it's still not it's becoming more diverse, and it's something we need to be aware of. So it's hard to make it relevant to absolutely everybody that comes, but we talk about cultural awareness, and then we need to adapt it using similar methodology to the way it was developed in the first instance for different cultural environments. And that is why when you partner with Australia, they tell you or they show you how it was done in their setting and in other countries where it's been adapted. And then you know, your country or your cultural environment can do that for where you are as well. So yes, that's really important aspect.
So you're just aware on the Chinese adaptation, but not really on any other language or culture.
There are 24 countries now that do the mental health first aid program, and that includes the UAE and Saudi Arabia. So
Okay.
you can, I couldn't understand the Arabic. I did look it up.
Okay,
But
so it is available in Arabic. Okay, that sounds.
there is a course in Arabic, and however, to access it, you would have to see if they were including other countries within that. So I'm not sure about what the parameters of their agreement with Australia are, for example.
Right. Okay.
To check.
Thank you for that. Thank you for that. That was a very important question, I think, for our audience. And another question also was regarding the effect size that you mentioned in the systematic review. What effect was measured, and what was that relative risk? So they wanted to know a little bit more information on this effect size.
So you're really testing me now here. My statistics. So they're looking at before and after doing the training and comparing people who haven't done the training to people who have, and trying to see, you know, what's the difference between the baseline and the post-training measurements for that. So I think they use the Pearson's correlation or coefficient. Am I right with that?
Yeah, I think that perhaps what the effect size is, depending on what the outcome is, that it was tested. So if it was knowledge, or if it was confidence, or if it was a stigma, I don't know what exactly was measured, but I think that the question was, you know, that effect size on the systematic review, what did measure?
So in terms of knowledge, what they tend to do is a mental health literacy evaluation, which is a standardized, I suppose, approach to knowledge in the area of mental health. So if you look at that, that's the test that they would have used. And then in terms of the what was the other one? Stigma, they would have either the social distance scale or the different scales that I mentioned earlier on. That's how they would measure social distance. So all of these are kind of they're standardized approaches in mental health in general or in social care, and they're quite careful through a lot of the studies to try and use similar methodologies so that we can compare the programs. So you can see there were 2 systematic reviews, and the inclusion criteria were different in each of them. We always need to have a look at that, so that they tried to remove the bias as much as possible from, by managing the inclusion criteria for those courses. But we do know that a lot of these courses are evaluated by the people who are running them, I suppose, so we have to remember that. And the attempt, I suppose, with a lot of the Swedish work is to do this a little bit more independently, and to examine and interrogate that information independently.
So I guess, I mean, just to guide the audience, I mean, they can access always the, the paper and the systematic review, which you have cited at the bottom of the slide. So for further information about it, specifically which questionnaires or which tools they used in order to assess either, stigma or knowledge, they will, it's always good to have access to that information so they can refer to that.
Yes. Yeah.
Great.
I can. I suppose I thought I'd mention just a little bit of our experience in Ireland, because it's important for every program to evaluate the intervention as best they can. And we did get an independent evaluation of the Irish program, because I suppose we're receiving public funding for this as well, and you need to be accountable and showing that you're delivering what I suppose the funders would expect from your program. So in the Irish context, we did a mixed methods approach, and they did a survey followed up by interviews. So I suppose from a delivery perspective, it's interesting to see who's coming to the course and why are they coming, why are they choosing to do it. And 47% did it because of their work or professional development, 43% for personal reasons, and then the rest related to maybe volunteering or working in their communities. So might have been that they volunteered with a sports club, for example, and they thought this would be a useful training. Many of the people did have previous contact with people experiencing mental health problems, or currently had experience of people who may have been close friends, for example, having a mental health problem. So there's often a very high baseline knowledge for people who are coming to do these courses as well. So within that context, I think you need to think about the effect size in that context, and what would it do if you made it mandatory training, for example, for a group of people. And then 80% felt that they were at least moderately confident after doing the course. So I think, some of the quotes are not, are interesting and help us contextualize and think about, well, how did it help? So people described feeling more confident because they could offer a structured response and a process to having the conversation, that the helping behavior improved, and that they'd offered their time to two people. Offering your ear to someone is our colloquial way of saying that, you listened without judgment, and that you could reassure them. That improved their understanding and awareness. And I think that's a big part of it as well, because we do have videos to explain from the person's perspective what it actually feels like to experience anxiety, for example, or to experience an acute psychotic episode. To tell that story is really, people find that really interesting and useful and impactful. And also having that algae, that framework and those skills, and solid advice, good advice and structured advice on what to do, and not to be afraid, particularly when asking somebody, for example, about thoughts of suicide. So they were talking about being able to ask questions directly, rather than, as we would say, dancing around the issue or trying to approach it from different angles without actually asking the question directly. But we have to think about also that there are challenges, and there are problems that people have identified. So you may be more confident after doing the course, but there's nothing like experience to improve your confidence. And if people felt if they had more experience, then they would be more confident. Sometimes they feel like there's a lack of services available. So when you're trying to support someone to access service, that can be a frustration if people don't feel that there are services available. That, in a work environment, for example, it might be difficult, depending on your relationship with someone, that they might not want to disclose having a mental health problem. And I suppose in that scenario, if you're showing that you have a good attitude, then at some point that person may feel they're able to confide in you. And maybe they don't want the help. And that's something that we talk about too, that people have autonomy in most scenarios, unless you think they're in a very severe crisis, that, you have the choice, and people may decide at a particular point not to take your support or advice or to access services. But if you approach it in the mental health first aid approach, then you will always be there if they change their mind or if they want support at a different time. So just to summarize, We know that it's effective, improving literacy, confidence, helping behaviours, reducing stigma. And there are some studies that say that you can improve participants' own mental health. And I suppose that's the thing about literacy. If you have good knowledge, if you think that there's hope, if you feel that there's help available, then that will improve your well-being as well. So in terms of its contribution to public mental health, what do we mean by public mental health? So that's a population approach aiming to sustainably improve population mental health by the coordinated efforts of public organisations, mental health services providers, voluntary organisations, local communities, and us all at an individual level. So how could it help? Well, it increases the number of people with mental health problems who can access help. And that's our hope. That it facilitates the spread of people who are capable of helping others. And it harnesses the capacity of existing community networks using a cost-effective train-the-trainer model of delivery. And that's something that I really think that this, whatever population health approach, that, the power of communities, and you're talking about next week social determinants of health, and the power of communities to support people and to support each other for all aspects of health is so strong. And if we can harness that, I think it would, it's a huge benefit. Right. So in terms of where it sits, this is just a graphic of when I was researching mental health first aid, where might it sit in all of the interventions that are potentially available. And really it sits in that area of early intervention. What can I do to help someone to access care early? And also in the suicide awareness and crisis intervention area. So that's where it sits. Some of those other programs are what were available in Ireland at the time. But, I'm sure that there are lots of different programs available where you are as well. And at the time we brought mental health first aid, and still there wasn't anything really in this space that bridged the gap between wellness-based approach and prevention and access to care or access to help. So these are just examples of our public health policies, and I saw that mental health first aid could support a myriad of public health policies, and it was quite easy actually to read these public health policies and to fit this training program within their goals and their aims, and show that it can work across different aspects of health and departments that run it in the Irish setting, for example. So I just highlighted too there, Connecting for Life is our suicide prevention strategy. And suicide prevention strategies usually cover a number of aspects. So they might cover things like reducing access to means, for example. Treating mental illness will reduce the rate of suicide. Reducing misuse or abuse of substances will have an impact on the number of people who take their own life. And another aspect is what they use is they call it Gatekeeper Training. So that teaches people to identify individuals who are showing signs of or warning signs or thoughts of suicide, and how you might help them to get the help that they need. So mental health first aid would fulfill the criteria for gatekeeper training as a part of a suicide prevention strategy. The other one that I particularly like that's run in Ireland is called Making Every Contact Count. So as a healthcare professional, by making every contact count, you can encourage people to make healthier lifestyle choices during routine contacts. And, many of the people who access healthcare services, are experiencing chronic physical health or mental health conditions. So if you can maybe introduce some brief advice or brief interventions during those contacts, you might help them or start to nudge or move towards healthy lifestyle choices, for example, stopping smoking, or even looking after your mental health. So that's a nice initiative, and mental health first aid would fit, I think, into the area of a brief intervention in that context. And then in terms of scalability, well, it's a train the trainer program. So that means that it is a scalable public health initiative. And I think we always have to be careful when you're scaling something like this, that you have a level of consistency and that everyone is delivering something, that there's a level of standardization in that and a level of quality assurance, and that we're all confident in our instructors and that the instructors are receiving the right supports and information in delivering the program. So there's a lot to think about in scalability, and a lot of, to ensure and that the integrity of the programme remains. And that's something we've thought very carefully about in Ireland, for example. From an occupational health perspective, there's a big interest in this area now. And you could be a bit cynical and say it's all about keeping people working, keeping them going. However, there's a huge cost to business in terms of the absenteeism or productivity, for example, that results from mental health difficulties. So there's a business case here, and it seems from an Irish report there that it's a very clear business case to invest in mental health initiatives in your workplace. So that's a report from CIPD. So CIPD is the Chartered Institute of Personnel and Development. So it's like the professional body for human resource managers in the UK and Ireland. And I just thought that was an interesting document, because what we're looking at there is that the biggest cause of long-term absence from work now is mental health difficulties. That's from 2020 summary. It used to be the musculoskeletal problems, but mental health problems have overtaken it. And 59% of these people, of the public health employers, or not public health, but public employees, so government employees, had reported an increase in the mental health conditions that they were encountering. So they've suggested lots of different, I suppose, supports for people there. And it's really important that in our workplaces that this is something we have a conversation about and think about, and what is it we can do at the prevention stage to manage things like stress or brief periods of mental health problems, and also to prevent those diagnosable illnesses that cause long-term absences. And we can't forget about our healthcare workplaces. And I thought this was a really stark study from, it's 2021. And it said that nearly half of healthcare workers reported serious psychiatric symptoms, including suicidal ideation during the COVID pandemic. I mean, that's awful, really, isn't it? To think that that's how our healthcare workers feel. And perceived workplace culture and supports contributed to symptom severity, as did, personal issues and personal circumstances. So whether it's mental health first aid, whether it's, some other interactions around stigma or access to care, building a good culture will have a significant impact, and it's so important in healthcare workplaces as well. But what the pandemic also did was it exposed a lot of the cracks that might have already existed within certain healthcare services, or pathways to care. So some of that might not be directly caused by COVID itself, but by the system and how it's, I suppose, experienced this pandemic and the gaps that are now there. So briefly, just to take a case study from my own professional background on how mental health first aid has been used in training for healthcare professionals. So as a pharmacist, we always say that we're the most accessible healthcare professional. We're accessible, you know, and also we're probably the most frequently attended healthcare professional for people who are taking medication for any physical or mental health problem. And the Australian Pharmaceutical Society have also, you know, expanded on our role in providing mental health care with direct and indirect services that we can do as professionals. So we have a huge contribution, as do all healthcare professionals, in the provision of mental health care. So I suppose the question is, are we doing it? And are we providing those services? And so what the research has said is that, you know, as professionals, we really want to be involved. We want to provide good care. But for many reasons, we don't feel ourselves that we're providing the best service that we could to people who are experiencing mental health problems. And there's a numerous factors involved in that, but one of them is that perhaps our undergraduate programs and approach to education isn't quite giving us the skills or equipping us with the knowledge that we actually need when we go out into practice. So, for example, this study found that the education provided was largely theoretical, didn't have much exposure to people who experience mental health problems, and that communication strategies were found to be a gap within the training. And all of that leads to reduced confidence then when it comes to working in practice. So we've looked, and in particularly in Australia, they've looked at whether this works, and it's in a similar, I suppose, a similar methodology to how mental health first aid has been evaluated in other populations. But what they found was that overall participants were more confident about providing pharmaceutical services, so pharmaceutical care to consumers with a mental illness following the training. So we have experienced that ourselves in RCSI, in the Royal College of Surgeons, and have actually integrated mental health first aid into the undergraduate curriculum in order to support our students when then they go out into practice. I thought it was interesting from some of our own evaluations to look at that whole story of self-reported confidence and how we feel as professionals. So we just compared the people who had a pharmacy background to participants who didn't, and just looking at, well, is there, you know, how are our, you know, you would think that the pharmacists would have a huge level of knowledge and skills in this area because they're healthcare professionals. We found that they actually rated their own confidence lower than the other participants. Now, the other participants were people who maybe have worked in health and social care or as volunteers for charities, for example. But I do think that self-efficacy piece is quite interesting and something that we need in all healthcare professionals to explore a little further. So it's been used for medical and nursing students, and it was introduced really in Australia in these populations to support people's ability to help each other at an undergraduate level. So I suppose in almost as a well-being intervention and to help students to help each other, which is important, I suppose, when you think about that big change that's there when moving into a very stressful course. Generally, most healthcare student or healthcare courses are intense, and there's a lot of expectation, and we find that people, you know, often seek help from their peers, not just from the, you know, support structures that are there for them. So they found that the online course, if they compared that to the face-to-face course, that it did work quite well. So I think people can have that choice, I suppose, in whether they want to engage in this program virtually or in the face-to-face workshop program. I'm a bit old-fashioned. I still prefer the workshop, but they both do they do show an impact. And this is only to say that, you know, social workers are doing this program, physiotherapists are doing this program. So as we said, every contact counts, and all of us will experience or will have an opportunity to help someone experiencing a mental health problem. And finally, I suppose I just wanted to come back to that piece about stigma that we spoke about earlier. And I think this is a really interesting area of research and something I've tried to read a bit about. And I suppose, what do we mean by stigma? What does that actually mean in you know, in the experience? So Thornycroft, Graham Thornycroft in London has been researching this for many years, and Claire Henderson, and they describe stigma as an overarching term with three elements: problems of knowledge, which might be ignorance or misinformation, attitudes or prejudice, and that results in particular behaviours or discrimination. And also that societal stigma can be internalized by people with mental illness, so that they'll accept these negative attitudes, and that will lead to low self-esteem or withdrawal from situations because they actually anticipate discriminatory behaviour. They may not have experienced it yet, but they anticipate that it might happen. So it might stop them, for example, applying for a job. And it's been described as a significant obstacle in the provision of effective care for people with mental illness. And it's one of the main reasons that people delay seeking help. So how might you see that? Well, one of the things that you could see is some, you know, diagnostic overshadowing, for example, where people's symptoms are put down to their mental health difficulties and may not be fully investigated because of that. So the experience and consequences of stigma have been described as worse than the mental illness itself. And then we have to think and reflect on structural stigma, which I think, again, is something maybe as educators or as people involved, you know, with students, for example, have to think about. So they describe that as discriminatory social structures, policy and legislation. So not funding mental health services to the proper level might be an example. It's evidence in poorer access and the resultant outcomes of that in terms of physical health, poorer quality, relatively scarce mental health services, and maybe inadequate coverage of mental health correct education in curricula. So one of the barriers I have come across in incorporating this program into the undergraduate program is, oh my gosh, we have so much to do, we have so much to fit in. How are we going to put 12 hours into mental health? But my argument would be that, you know, actually people are going to use this quite frequently. They're going to find it helpful and useful. And when you consider the scale and the, you know, the proportion of people who are experiencing mental health problems, and you try and design your education to meet that need, then it's certainly worth the 12 hours of time that we give to it, certainly in the RCSI program anyway. So that's what I wanted to talk about today. Hopefully I've given some context to the scale of the opportunity that we have to improve mental health. We've looked at the mental health first aid approach in terms of, you know, it as an educational intervention. And I suppose there's learning in that, really, just in terms of how you develop a mental, you know, an educational intervention, and how you might go about, you know, finding out if it's of any use or not, or is it working. That we can appreciate how a program like this supports a public mental health policy. And I think that's, as we've described, increasingly important at the moment. And we all know that early intervention improves outcomes in lots of different aspects of our physical and mental health care. And then to reflect a little on our own, well, me as a healthcare professional, and you know, within the people I train and the, you know, the education we provide, how can it be incorporated into that, and is it meeting the training needs of existing mental health professionals as well. And I suppose finally, I like this quote from, it's an English, a think tank is what it's called, Nesta. And it said that the mental health first aid program enables committed, passionate, and open-minded leaders to emerge from anywhere. And so I think that's a better answer to the question you asked earlier on who should participate in mental health first aid. Everybody should. So thank
Thank
you.
you very much, Dr. Dolores. This has been a very insightful presentation and a very nice way to close the session today with this quote. We have very good questions, actually, that I would like to, if we have a couple of minutes, to present to you. And I will just have to leave the other questions for to be answered by you maybe later on to our audience. But we have a couple of really good questions that I wanted to pose before we close. And number one is, local community leaders in this part of the world tend to be religious leaders, such as mosque imams.
Mm-hmm.
Have you seen any successful engagement of religious leaders in this program?
Yes, we have. So I know in the UK that they would have rolled this program out amongst the Church of Ireland groups, for example. I think in Ireland, I'm not sure if this is unique to Ireland, but religious communities tend to provide a lot of health and social care and even community initiatives. So it would have been used within, say, for example, Cross Care is a religiously run and coordinated group helping people from more disadvantaged areas, for example. So absolutely, it can be used within the religious communities to help. And I suppose what it helps there is the signposting is particularly useful because we know that, people, religious leaders would be very good at listening often, but they might not have, all of the information they need in terms of signposting and supporting people with um, evidence-informed information on what might be helpful for them. So I see where that can work.
Thank you very much for that. And also another question that I thought it would be very good for you to answer would be regarding students who have successfully been trained and deliver service as a mental health first aiders. Do you have any experience with that?
Yes, so my own experience is that we've been doing this work with students since 2015. So the way we started was we invited people who wanted to participate. We said, if you would like to come forward and, put your name down, we'll provide this training for you. But that evolved into it being mandatory training. So something that everyone engages in. So in terms of how they've used it, we haven't done a follow-up study ourselves. We do have feedback that is provided through the university, for example, on whether people found it useful. So we published a survey on mental health first aid and student experiences of it recently. So that's a paper I can share with you. So the students felt that it was useful. They felt that it was something that they wanted to participate in. Now, obviously, it's a survey, so maybe only the ones who enjoyed it answered the survey, with all those caveats. However, we did get examples of when they'd actually used the training. And one story, for example, was a student who said that their friend experienced suicidal thoughts and that they, having participated in the training, were able to support that person to access help. And, we get anecdotes like that. So in terms of an overall piece around, is this having an impact on the profession and our ability to engage. I think that's something we need to follow up on. Yes, we're yet to do that. There have been some studies in Australia asking people who have participated in it, how they feel about it and how they've used it. So we do need to follow through on that, and we need to keep that capacity building going on, and make sure that people do have those opportunities and that they can make the most of them in the healthcare setting.
Yes, thank you very much. I do agree with you that this is something that perhaps universities should be looking more closely, and having students helping each other, being trained with a validated program like this one would be very useful for going forward, especially after the experience we have had with the pandemic. So I don't have any other questions. We have a lot of comments from our audience regarding the great presentation you have been able to deliver today to us.
Thank you.
Very important topic. I think we all recognize that, and we appreciate the efforts and all the information that you have provided us tonight. If Dr. Zach doesn't have any other information or any other announcements, I would like to thank you again for this great presentation, and I hope that the audience also have been able to enjoy this presentation tonight. Thank you, Dr. Dolores.
Thank you very much, and thank you to everyone who's attended. Appreciate it.
And also on behalf of the CPD department here at Cutts University, so thank you very much. Very important and very insightful topic that I feel has a lot of potential here locally. So thank you very much, and thank you again to our participants who brought some really insightful questions to today's discussion. So thank you very much for joining, and we look forward to seeing you next week's event, Social Determinants of Health and Clinical Outcomes with a focus on diabetes. So thank you very much, everybody, and good night.
Thank you.
Thank you.